Great. Well, our next speaker from the Minnesota Department of Health is Anari Mohammed. She's a third-year PhD student studying infectious disease epidemiology at the University of Minnesota School of Public Health. She's also a COVID-19 epidemiologist at the Minnesota Department of Health, and her academic work focuses on infectious disease prevention, social determinants of health, women's health, and marginalized communities. So I'm going to join Anari and welcome her to the LeadMN VAC Summit.
All right, thank you. Oh, can you give me permission to share my screen, please?
Yeah, Jocelyn, if you could do that.
Okay. You're seeing the presentation right now, like not presenter mode?
That's correct.
Okay, great. All right, so today I will be talking about how we can bring health equity to vaccine outreach. So my presentation will briefly go over the epidemiology of COVID-19, morbidity and mortality, underlying causes of health inequities, the importance of COVID-19 vaccination for communities of color, vaccine hesitancy among marginalized communities, and how we can improve vaccine uptake and move towards a more equitable future. So here we have data from the Centers for Disease Control and Prevention. When we look at epidemiological data for infection, hospitalization, and death by race and ethnicity, we can see that individuals in the American Indian or Native Alaskan community are 1.6 times more likely to be cases, 3.3 times more likely to be hospitalized, and 2.2 times more likely to die compared to white Americans. And these disparities hold for almost all other communities of color.
No, I cleaned out my office. Oh my God. I also, did you forget?
We see that Black or African Americans are equally likely to be cases compared to white Americans, but are 2.6 times more likely to be hospitalized and almost 2 times more likely to die compared to white Americans. And we see that those numbers are similar for Hispanic or Latino persons. When we look at COVID cases among children by race and ethnicity, those same disparities continue to hold. So these are cases among children per 10,000 population. We see, again, Hispanic children and American Indian and Alaska Native children are much more likely to be cases. And then it sort of worsens when we look at hospitalizations. Black children, Hispanic and American Indian and Native Hawaiian and other Pacific Islander children are more likely to be hospitalized and also, unfortunately, much more likely to die. So what is causing these disparities in cases and in vaccine uptake? So it's important for us to understand structural racism, because structural racism is really what drives the it's really what drives the disparities. So structural racism is the ways in which society perpetuates discrimination by reinforcing inequities within the various structures that comprise society. Discrimination in one sector of society reinforces discrimination in other sectors, resulting in an intertwined system of inequities that influence education, housing, employment, health, justice, and the laws and policies that drive these systems. Unfortunately, racial disparities in health outcomes are often blamed on presumed biological differences among races, poor decision-making, or specific cultural practices. For example, for a long time, there was this prevalent idea in the medical community that Black people are more tolerant of pain compared to white people. So Black patients were a lot less likely to get appropriate pain management because of this thought or this idea that they were more tolerant, biologically more tolerant for pain, which is untrue. But is these modes of thinking that are harmful because they really function to disadvantage people of color in healthcare. So what are social determinants of health? So these are, social determinants are the conditions in the environments where people are born, where they live, where they work and worship and age that affect a wide range of health, functioning, and quality of life. So healthcare access and quality, education access and quality, social and community context, economic stability, neighborhood and built environments. I just mentioned earlier that, these factors are intertwined. So if someone has difficulty accessing education, say because, they live in an area with lower quality schools, that can affect their ability to maybe go to college, which affects their ability to maybe get a job with adequate healthcare access, which can affect where they live, which can affect their health. So all of these things are really intertwined. So inequities in these areas drive poor health outcomes and these inequities become especially worse during the COVID-19 pandemic, leading to higher morbidity and mortality among marginalized communities. So why is it so important that communities of color get vaccinated? Well, people of color are overrepresented in essential worker fields such as retail, farms, factories, long-term care facilities. They're less likely to leave their jobs if they don't feel safe at work, more likely to have higher rates of chronic health conditions that predispose them to severe illness and death from COVID-19 infection. And they often live in multi-generational housing and are likely to face challenges accessing healthcare. These and other reasons are why it's so important for people of color to be fully vaccinated for COVID-19, but data shows us that vaccination is lagging among marginalized groups. So here's some data from the Kaiser Family Foundation. We see that, for part of last year, we see that, the ethnic group or the racial group that's actually doing really well in terms of vaccination are Asian Americans at 77%. But what this doesn't tell us is that how are different populations within the Asian American group doing? We can't tell how Hmong Americans are doing versus Chinese Americans versus Southeast Asians. So that's just something to keep in mind whenever you see data that groups large populations. But we can also see here that Black or African Americans are doing the worst in terms of vaccination rates. And then as for Minnesota, this is all data from the Minnesota Department of Health. We can see that for vaccine completion for all Minnesotans over the age of 5, again, Asian Minnesotans are doing pretty well. But numbers really drop when it comes to American Indian communities, African Americans, and multiracial and Hispanic Americans. So what is causing vaccine hesitancy among people of color? There's a lot of discussion in terms of concerns about side effects, and Mary addressed some of those a few minutes ago. There's a lack of knowledge about the vaccine development process, distrust of healthcare systems and of physicians, perpetuation of false information about the vaccine by either word of mouth or through social media, and lack of culturally appropriate outreach from public health and healthcare systems. And then I'm going to focus a little bit more on vaccine hesitancy in the African American community. The history of medical experimentation and abuse among African Americans is long. It really goes back to slavery and complex, and includes, the Tuskegee trial of this Tuskegee study of untreated syphilis in the Negro male, which I think a lot of people have heard of. There's the story of Henrietta Lacks, J. Marion Sims, the father of modern gynecology, and Holmesburg prison experiments. There's a lot more, instances of medical experimentation that also include other, races and ethnicities, but I'll just go into detail on the 4 examples that I listed. So J. Marion Sims was in the 1800s, was known as the father of modern gynecology. He conducted painful surgical procedures on pregnant and postpartum enslaved Black women without anesthesia. And he used them in order to perfect these surgical methods so that then he can implement them on, wealthier white women. And so, he's not someone who's talked about a lot, but I think it's important to remember what he did and what he did to the enslaved women. And then we also have Henrietta Lacks, an African-American woman whose cells were harvested by Johns Hopkins University when she went in to get treated for cancer. And they were harvested without her knowledge and permission and have been used extensively in medical research for decades, making millions for the Hopkins as well as other pharmaceutical industries that used her cells to develop drugs. And her family still hasn't been sufficiently compensated. Another, again, Tuskegee comes up a lot. So it's a study where 400 African-American men were denied treatment for syphilis for nearly 40 years as part of an experiment under the US Public Health Service. And so, it's still, the people who were part of the study and their children and their grandchildren are still alive today. And then lastly, a less well-known experiment occurred in Holmesburg Prison in Philadelphia. And it was a site where decades-long dermatological and pharmaceutical experiments were conducted on prisoners, things like injecting acids into the skin or exposing prisoners to chemicals and irritants to see what that does to the skin. And then lastly, I want to mention that these experiments were not just limited to Black people or even to the United States. In 1946, doctors from the US went to Guatemala and infected marginalized people with syphilis in order to study the natural history of syphilis. So it's important to note that, these things have happened beyond our borders as well. So beyond history, things that cause medical mistrust today are implicit racial and racial bias among healthcare professionals, provider perceptions, or the way that providers perceive and behave towards patients of color, lack of providers of color, low health literacy among communities of color, and language barriers. So how can we address some of these issues in our vaccine outreach? Accessibility. So, making sure that we have our vaccinations are accessible to people, whether we bring it to them or, find ways to bring them to us. Make sure information is in a language they understand. And that means whether it's translated, it's in images or audio, or even, not having like science-y language, just making it, super general, understandable for the general population. As part of my PhD work, I've been interviewing Black women in the Twin Cities to see the kind of challenges they've faced or, what they think about the vaccine. And I had one participant say that it was very difficult for her grandma to get vaccinated because she was an immigrant. And the vaccination spot was Mall of America. And earlier on in the pandemic, people weren't allowed to bring like a family or friend to the vaccination location. So she, she said her grandma was 80 and she wasn't going to leave her alone at the Mall of America to get vaccinated. So that was definitely a challenge. Engagement. It's important to involve community members in all aspects of program planning and to have consistent messaging, and to also have a non-judgmental, open attitude. There was one woman in my study who said, yeah, there's definitely a lot of judgment out there when it comes to, telling people that you're not vaccinated. I feel like people kind of take 2 steps back away from me. And some of these people don't really care to know why I feel the way I feel or care to address the concerns I have. And she went and talked a lot about sort of historical trauma, Tuskegee Tuskegee and personal incidences she had with the healthcare system that made her very nervous about getting vaccinated. And she really wanted people to really care about that and to know those things have happened and to talk to her about them. And then lastly, good communication. Try to understand reasons for hesitancy and address them as honestly and to the best of your abilities. And explain what you know about the vaccine without getting into the weeds. This is another participant who said, you know, even if it's like Zoom classes, I would be comfortable with that. Like their town hall meetings about taxes being raised, they should have the same things done for COVID vaccine. Like if people genuinely want to know the science and how this came to be, they should offer up that information. I think that on a personal level, like being able to talk to somebody, and I don't know how they would get to the people who necessarily may not have access. So she just had questions and she just wanted somebody to answer them for her. And through the various interviews that I've done with, you know, women in the community, people just want to have someone they can talk to express, you know, their concerns, and they want answers. And I think being equipped with information and being prepared to, you know, to really understanding the things that drive vaccine hesitancy so you can have good answers when people have questions, I think is important. Okay, I'm all done. I think I only used half of my time. I talk really fast. So thank you. Yeah, questions?
There are no questions so far, Anari. Any questions that folks want to throw in the chat? So Anari, I just want to thank you for taking the time and kind of sharing how we can really bring an equity lens to this work, understanding just really the past issues. Sorry. The past issues that different BIPOC communities have experienced and why that leads to the hesitancy challenges that we see. So thank you very much. And that'll be important as we develop our plans to kind of consider that perspective and to understand how we can overcome some of those challenges. There is, I guess, one question here. The question is from Ms. Shanita, is are there any studies done on why other races have a higher change getting COVID, other different races. So is there anything done on kind of showing how different races may be more susceptible to COVID? I think that's kind of the question she's asking.
Yeah, I don't think any race is more biologically predisposed to getting COVID. I think what we see with COVID is what we see with a lot of other health issues is that because of structural racism and these systems that have continued to disenfranchise communities of color, people of color who end up doing are being more likely to be essential workers or more likely to live in larger households or less likely to have access to healthcare. Because of those things, they're more likely to get COVID. It's not like a biological reason. It's a social and racial racism related reason.